This is a great malocclusion to treat where we have similar amount of upper and lower crowding. And so we can look at an initial ClinCheck that is not bound to go very well, and then one that is very predictable. You can see the comments that I made to the technicians to do most of the work to get to this much more predictable plan. But then I also use a little bit of the 3D controls, and here's some of my other final comments here. So I'll leave those up. Looking at this ClinCheck plan, when we go through, I can see a lot of molar movement, trying to move this second premolar. That's not going to be a predictable movement, even with an attachment. The anterior looks like this might work pretty well, and we do have some lower IPR, which fortunately helps finish with a nice amount of overjet here. And then you can see even more molar movement on the other side. But looking at this patient's initial arch form, they already have a sufficiently wide arch. It's really just uncrowding, mostly canine through canine. So this is not a case that would really warrant moving the molars, and the second molar movements are never going to reliably happen. And then from there, I like to look at the premolars and see what's going on. I like this optimized expansion support attachment. It works really nicely for a retention attachment, so the aligner is well engaged with the arch. When the aligner is well fitting all the way through the arch, every other movement that we're trying to do, like correct lower rotations or intrusion, is going to be more predictable. I can see that this has an extrusion movement, and by the look of this attachment, there's also some rotation. So let's look at why that tooth might be extruding. And it starts off without much of an occlusal point. But if without the rotation, if we could just upright and just tip the premolar to the buccal using crown tipping, then that's going to finish in a heavier occlusal position, and using a retention attachment like this can then hold on to the tooth better, where we can just do some very simple expansion movements. I do the same thing for the other side, and then look through the upper arch. I look and see that this premolar is rotating. Look from at the beginning, and yes, although it's in a little bit of a rotated position, it's really not a very big noticeable movement, so I'd rather just do expansion instead. I also find these attachments to not be very effective, so I generally will change these to the optimized lateral support attachments. An attachment that's more centered into the tooth, for the most part, is going to be more effective. And then let's take a look at the IPR. It looks pretty similar, but I did increase it where the teeth have the most area of finishing with a black triangle, so that we can increase the length of contact point there and also give us a little bit more overjet at the same time. I added bite ramps here because we always want to use those to not allow the molars to passively intrude throughout treatment. And I also asked to have the IPR done a little bit earlier because this is an example of round tripping, where the teeth are moving out, late IPR, and then pulling back in. So I looked at when we could possibly be able to slip an IPR file through there at the earliest, and I guesstimated about aligner 7, anywhere between 7 through 10 would have been sufficient. Really do not need to wait until after aligner 10 to do IPR for this case. That significantly reduces the amount of aligners and also helps protect the buccal bone from not having these teeth come too far forward and then come back. The other thing I see is that we no longer I want to check if there's extrusion really planned on this tooth and if we need this attachment. And also, since I do have a little bit more lower IPR, and I see that these teeth do finish with a black triangle, that is one that I may want to, that's no longer extruding, so we can remove attachment. I may just want to kick up the IPR here just a little bit, and that's doctor preference, but that leaves enough sufficient overjet that we're not going to run into an anterior interference, doesn't take off hardly any significant enamel, and just can get an overall nice finished look to the case. So I can just click live update, I'll get the next ClinCheck back, and then it'll be ready to approve.